Thank you, Dr. Rishabh. Thank you, Dr. Prashant. So I have been given this Herculean task to cover non-Hodgkin's lymphoma. It's a heterogeneous group of tumors with prognosis ranging from very excellent prognosis in untreated in patients who are observed to few months in aggressive primary CNS lymphomas. Already we have gone through the WHO list of classification, which is a very long list. Treatment varies from observation, radiation alone, chemotherapy alone to combined modality treatment. So I'll be briefly talking about the aggressive B-cell lymphoma, that is DLBCL, follicular lymphoma and MALT in the indolent variant, and if time permits, the others. So let's make our learning a little easier with case scenarios. First, the role of RT in DLBCL is established in early stage, advanced stage, and refractory stages. So as Dr. Rishabh highlighted, the contemporary trial evaluated the role of radiation in the PET and the rituximab era. Let's come to the case scenario. This is a 64-year-old lady from Ukraine with history of thyroid nodule. So as you can see, there was a left thyroid nodule which was biopsied and it was non-diagnostic. But over the time, she underwent a PET and there was FDG avidity only in the left side thyroid nodule. She underwent left thyroid lobectomy with histology coming as DLBCL. So what might be the other prognostic factors which we might want to look at it? So as Dr. Moushami highlighted, the GCB types have a better prognosis, and those with MYC and BCL2, that is double hit, and with additional BCL6 have a poorer prognosis than non-double hit lymphomas. So coming back to her case, how do we prognosticate her? So she has all the good prognostic features other than her age, which is more than 60, that's 60. So in the International Prognostic Index, she comes in the low risk stratification and she's going to do good in the long term. In the revised IPI, that is in the era of rituximab, which is validated in the era of rituximab, she comes in the good prognosis group. So how was this role of radiation established in the rituximab in the pre-PET era? This is a very old study of SWOG 8736. Which included mainly stage 1 DLBCL patients with a median follow-up of 17.7 years, and with 72% of the patients having either no risk factors or a single risk factor. This study proved that CHOP of 8 cycles was equivalent to CHOP of 3 with radiation. But then nowadays we do not follow CHOP of 8 cycles. So where do we stand? Recently, the LISA 0203 study was published, which was the role of radiation in the rituximab and in the PET era. This included stage 1 and 2 DLBCL less than 7, where it was randomized to radiation arm and no radiation arm. The study design is a bit complicated. Basically, here stage modified IPI index was considered, that is more than 60 years, LDH level, stage 2, performance status. If any one of these factors was present, they went on to receive 6 cycles of. But then here, after 4 cycles of R-CHOP, they had a response PET CT scan. Irrespective of the stage modified IPI, if they had any partial response, they received 2 more cycles of R-CHOP followed by radiation. So as we can see, this was a very favorable cohort group with 56% of the patients having a good prognostic IPI index. 19% did not have any gross disease before the chemotherapy. Just as in our example, the patient underwent a thyroid lobectomy. She did not have any disease. The local disease was already addressed. And 64% of the patients were less than 60 years. So what I want to highlight over here is 43% of the patients received more than 4 cycles of R-CHOP. That is indicating that 6 cycles of R-CHOP is what the current practice is. So as expected, there was no difference in the event-free survival with addition of radiation therapy. And there was no difference in the event-free survival in the complete response versus the partial response arm. So, but then, as we can see, there is definitely a role of radiation in converting the partial response patients to complete response patients at 5 years event-free survival. That is, those who received radiation improved the local control. Those who received only R-CHOP had 13 relapses, 5 were at the initial site, and none were in the irradiated site in the R-CHOP plus RT arm. But the caveat of this study is it was a very short follow-up. Unlike the SWOG 8736 study, the follow-up was long. Here, we do not know the long-term relapse rates. So it established that RT may be omitted in patients with favorable low volume disease with metabolic complete response after 4 cycles of R-CHOP. But then when this result was published, it made clinicians a bit skeptical. There was no direct comparison between R-CHOP 4 cycles versus R-CHOP of 3 cycles and radiation. So basically, FLIRE study was a chemo de-intensification study. Here, very favorable patients were included, that is AI patients, and all patients were less than 60 years. This was a randomized non-inferiority study between 6 cycles of R-CHOP versus 4 cycles of R-CHOP plus 2 cycles of rituximab. But then what we need to look at it is, although radiation was not allowed, 5% of the patients went ahead to receive radiation. So it established that we can safely be reduced to R-CHOP of 4 cycles plus rituximab of 2 cycles for young favorable patients. The next study is the SWOG 1001. This is where the role of radiation was established in the rituximab and the PET era. But then this was a phase 2, but a PET adapted study where less centimeters stage 1 and 2 DLBCL, non-bulky DLBCL were recruited. Here the patients received 3 cycles of R-CHOP followed by PET response. So what we can see is if they had complete metabolic response, they went ahead to receive 1 more cycle of R-CHOP. And if they had any partial response, the dual score 4 or 5, they received consolidation RT with radioimmunotherapy. So here, compared to the LISA 0203 study, there were less favorable cohort groups which were included. 27% of the patients were stage modified IPI of 0 compared to 56% there. 10% were without gross disease compared to 19% over there. And here, 46% of the patients were less than 60 years compared to 64% over there. So 11% of the patients were PET positive. 67% got converted from partial response to complete response after irradiation and Zevalin. So this highlights the role of radiation for partial response, and it is in terms of the results which were published in the LISA and the study. Coming back to a case, so I would have treated this lady with 3 cycles of R-CHOP followed by consolidation RT of 30 gray. She would have otherwise received 6 cycles of R-CHOP based on the LISA study because she's beyond 60 years of age. But then we need more data on R-CHOP of 4 cycles for older patients. So what is the data? Why do we prefer combined modality treatment and not full course chemotherapy in such patients? The SEED database suggests that the overall survival rates are the same, but then the freedom from second-line treatment is better in combined modality treatment. And also there are lower toxicity rates, that is hematological neuropathy are less with combined modality treatment. And moreover, older patients may have cardiac comorbidities, so they're exposed to lower anthracycline. So what about the dose for aggressive non-Hodgkin lymphoma? The famous BNLI randomized trial established this. Here it was compared between 40 gray to 45 gray versus arm. Although this was a heterogeneous group, there were 13% relapsed recurrent refractory cases, 18% palliative. The primary endpoint was overall response rate, and secondary endpoint was freedom from local progression. So as we can see that it was similar in both the studies. There was between 2 arms. So it was established that dose can safely be de-escalated to 30 gray for aggressive non-Hodgkin's lymphoma. So what would be the clinical practice guidelines for early stage DLBCL in non-bulky less than 7.5 centimeters with no risk factors, R-CHOP of 3 cycles with ISRT, or R-CHOP of 4 cycles if they're PET negative. This PET negative is when a local treatment has been addressed. Basically, we are not giving radiation. So if the patient has undergone a gross disease resection prior to the chemotherapy, then this can be adopted. And if they have any risk factors, then either R-CHOP 3 cycles with ISRT or R-CHOP of 6 cycles can be considered. And there is definitely a role for patients who have a PET-based partial response. So let us take another example. This is a 51-year-old lady who had a prolonged healing after dental work. Her CT scan was suggestive of an 8.3 centimeter tumor in the right masticator space, maxillary sinus, and the nasal cavity. Biopsy was DLBCL, GCB type, and MYC negative. PET-CT was suggestive of a stage 4 DLBCL with bulky involvement. She received 6 cycles of R-CHOP, post which the response, it was dual 4, so she was consolidated with ISRT. So what is the role of radiation in bulky DLBCL? As such, there's no direct study, but this has been adopted from the Recover 60 study. This is basically a chemotherapy study. So this is a prospective non-randomized sequential arm study. The best arm of recovers 60 arm was chosen, where patient received 6 cycles of R-CHOP, followed by 2 cycles of rituximab, followed by IFRT to the bulky sites. After the accruement, they were sequenced to either receive radiation or not receive radiation.
We have 5 more minutes.
Yeah. So as we can see, the blue line has good survival benefit, the progression-free benefit in both the arms. So definitely there's a role for radiation and skeletal involvement. That is, when patients have bone involvement, there is role with which improves the event-free survival. Although this is not mandated, but there is consensus that radiation has a role. So my clinical practice for DLBCL with risk factors will be RT should definitely be offered with patients with bulky disease or with skeletal involvement or with metabolic partial response. Radiation should be supplemented to full course chemotherapy, although most studies are required for this. There definitely is a role for relapsed refractory DLBCL. What I want to touch upon over here is the bridging to the systemic therapy in the palliative intent. So as we all know, the new novel therapy, which is upcoming now, the CAR T cells, as sir will be talking later on. So where can we bridge our CAR T radiation in this? So as we know, there's a timeline between leukapheresis and the T cell infusion. There's a time lag. I mean, as yesterday we got to know that it is even more at the US. So what can we do? We can intervene in the beginning only for the symptomatic control or the preservation of the performance status of these patients. And radiation does not appear to decrease CAR T cell efficacy. So we can consider this. So RT would be an effective bridging therapy in aggressive relapsed lymphoma, as they're chemoresistant, but they're radiosensitive. Majority of them have relapses, have the local component, and they have an excellent local control and durable response, and they do reduce the tumor burden, reducing the T cell severity, the T cell toxicities. So the role of radiation in follicular lymphoma in localized disease, which is considered to be the curable stage 1 diseases or contiguous stage 2 diseases, radiation alone is the only treatment, where 24 gray is the dose which is preferred. And in advanced stages, relapsed refractory stages, that usually considered incurable. If they fail to be either on the system, according to the GELF criteria, they can go ahead to receive systemic therapy or they can be observed. But then there is a role of palliative radiation of ISRT of 2 gray into 2 fractions, which is the famously known as the boom boom therapy. So I'll skip this slide in want of time, and this is again the flowchart highlighting the role of radiation in follicular lymphoma. So what are the outcomes? Basically, these are based on the ILROG studies. These are retrospective study which proved the benefit of radiation in local control, which was around 97.6%. With the modern PET-based era, we know the stage migration, but then the previously underestimated role of radiation's curative potential has now been established for truly localized disease. And then again, coming back to the BNLI study, which was there, this again drives home the point of 24 gray. Can we go lower than the 24 gray? No. The fourth non-inferiority randomized trial, which tried to reduce the dose to 4 gray, but then no, 4 gray is reserved for only palliative setting. So I just want to touch upon this, the contouring volumes. This is basically a 70-year-old gentleman with stage 1, grade 1 to 2 follicular lymphoma of the right groin. So what we do is the CTV should be generous, because this is the only curative treatment he's getting. He's not getting any systemic therapy. So CTV margin should be generous. It should involve the adjacent nodal regions. A bit about marginal zone lymphoma, the MALT-based extranodal MALT lymphoma, the nodal and the splenic. The gastric MALT nowadays, there is a necessity to do the H. pylori testing. If they are positive, then translocation 11 and 18 should be tested for, because they are associated with higher rates of relapse and the 6 cycles, this lady showed dual 4 response. So what do we do now? So the PMBCL recommendations based on the EOC PET study, that is for the dose, after dose adjusted R epoch 6 cycles, if they are PET negative, no further treatment is required. But then if they are PET positive with low SOV values, they can be put on closed active surveillance, or they can be considered for biopsy, or upfront ISRT can be given to the involved sites. But then if they are PET positive as well as biopsy positive, then they should be considered for ISRT followed by ASCT.